The CheckMate-064 was a trial written by Steve Hody and by me, which became a BMS-sponsored trial that ultimately evolved to a randomized phase 2 trial. This was a trial in which 140 patients were randomly allocated to receive sequential immunotherapy. And when I say sequential immunotherapy, patients were randomized 1-to-1 to receive 12 weeks of induction nivolumab in what we call cohort A, followed by a forced switch to 12 weeks of ipilimumab, and then maintenance nivolumab every other week at 3 milligrams per kilogram until progression, toxicity, or refusal. Arm B, or cohort B, had the opposite sequence: 12 weeks of ipilimumab at the standard dose and schedule, 3 per kilogram every 3 weeks times 4. And then there was a forced switch to nivolumab every other week, 6 times at 3 milligrams per kilogram. So cohort A and B varied only in the reversal of the sequence. The actual total treatment would have been the same in either cohort, just the timing was different. And in cohort B, you also went on to receive maintenance nivolumab until progression, toxicity, or refusal. And the endpoint actually was not clinical efficacy. The primary endpoint was actually grade 3, 4, and 5 immune-related adverse events by the end of the second induction cycle at week 25. The toxicity data, to our surprise, showed that even though in the first induction cycle there were no surprises, right, because they were only receiving one drug, either Nivo or Ipi, as their initial treatment, you had about a 7% grade 3-4 treatment-related adverse event rate for the Nivo arm in cohort A, and it was about 20-some-odd% in cohort B, who got Ipi. But again, the surprise was by the time of the finishing of the second induction cycle at week 25, you actually had more toxicity in arm A at about 50% versus about 42-43% for cohort B. And that's getting up to the rates you're seeing with concurrent therapy.